Welcome everyone. My name is Brad Chickwin, and today we're going to discuss all the medications in our drug box and narcotic box as it applies to the Maine EMS protocols 2025 version. Also, it'd be very helpful for this presentation for you to be able to pause it occasionally so you can read the screen, as well as having your phone out front of you with your protocols, because this is not an in-depth review of our protocols, just covering the medications and different uses for them. What we're going to cover today is basic medical terminology, the who, what, when, why, where, the onset, how long does the medication last, how it's commonly packaged, and at the end we're going to review MedMath 101 with some scenarios to which we would utilize and deploy the medications on our patients. In the upper left-hand corner on some of these slides, you'll see either an E, an A, or an M. What that means is this medication is able to be given at the EMT level, the advanced level, the medic level. When it comes to this, if you see an E on that slide, it means it's able to be given by all three levels. If you see an A on the slide, it means it can be given by the advanced EMT and the paramedic. And then if you see just an M on the slide, it's medic only. Medical terminology. So some things you'll see on these slides, PO means by mouth, SL means sublingual. You'll see some verbiage referring to alpha 1, alpha 2, beta 1, and beta 2 receptors. Think one heart, two lungs when it comes to beta. Sympathetic nervous system, that's our fight or flight response. Parasympathetic nervous system, that's the calm and composed response, so the opposite of fight or flight response. Agonists and antagonists, think of agonists as the good guys and antagonists as the bad guys. So let's start off with the respiratory system and the medication we use to make it better. Oxygen. As you can see, we can use oxygen in a variety of different ways, whether it's mass, whether it's a BVM, or whether it's a CPAP. Oxygen. The goal with our oxygenation is to be a clinician and not a technician, meaning the old school mentality of IVO2 monitor every patient no longer applies. We have learned that if we give oxygen in high amounts for no reason at all, we can make our patients worse. For example, our head injury patients, we don't want to over-oxygenate due to hyperventilation and vasoconstriction. So oxygen, our whole goal of oxygen is to reverse hypoxemia. It binds the hemoglobin in the cells for delivery to organs and tissues. Our goal is when we give oxygen to our patients that we monitor them both with the SpO2 and end-tidal CO2. Remember, our goal is an SpO2 greater than 94%. We're no longer shooting for 100%. Remember, our COPD patients typically live in a high 80, low 90s state and may never get higher than 94%. We can give it as a nasal cannula non-rebreather, a positive pressure ventilation. That would be our BVMs, and also don't forget about CPAP. Onset, it's pretty immediate through all those devices and durations. As long as we leave it on them, it works. As soon as we take it off, then the body tries to maintain without it. Epinephrine, 1 to 1,000, also known as 1 to 1. EMT level, so we can give it right across the board. It's a sympathetic agonist, meaning it is a symptomimetic. It blocks histamine receptors and overruns the sympathetic nervous system, meaning fight or flight with adrenaline. We should never, ever, 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 ever give Epi 1 to 1,000 IV. Even if you have an IV established because you've given other meds or giving fluids, and the person's having an allergic reaction, make sure you still give it IM. The onset for this medication is about 30 to 60 seconds. The duration is 15 to 20 minutes. This is good to know because if and when you have a patient with an EpiPen and is deployed in the field, it could wear off in 15 to 20 minutes depending on how severe the allergic reaction is. For adult patients, the dose is 0.3 milligrams IM, and for pediatrics is 0.15 milligrams IM. The cutoff weight for a pediatric versus adult is right in that 45 to 50 pound range. If you're ever hesitating on whether or not to give the adult or pediatric dose because the patient may weigh 50 pounds or maybe 45 or 60, just go ahead and give the adult dose. That way they know they're properly medicated. You don't want to underdose your patients having a life-threatening allergic reaction. Benadryl. What does Benadryl do? It blocks histamine receptors that cause bronchoconstriction and vasodilation. We give it in conjunction with our epi during allergic reaction and anaphylaxis. We need to make sure not to give it to a patient who's acute asthmatic because Benadryl can cause them to be drowsy or even become sedated, and we don't want to knock out the remaining breathing effort of these patients. Benadryl should always be second to epi. We can give it IM, IV, or IO. How much should we give? For adults, 25 to 50 milligrams, or pediatric is 1 to 2 milligrams per kilogram to a max of 50. The onset's about 5 minutes, and it lasts about 4 to 8 hours. Albuterol. Albuterol, also known as Proventil or Ventolin, is a fast and short-acting smooth muscle relaxer in the airway tract, and it allows for increased airflow to the lungs. Most effective with asthma patients due to the bronchodilation in the acute setting with an immediate onset, less than 5 minutes, and it works really, really well with corticosteroids. After you give it, the patient might experience lightheadedness or irritability or tachycardia. That's okay. Remember, if we can lower the respiratory rate, making the effort easier, the heart rate will naturally come down anyway. The onset's about 5 minutes when you give these nebulizer treatments, and it lasts about 3 hours. Ipratropium bromide, also known as Duoneb, given at the EMT level. We also call it Atrovent. So it's an antagonist with the action of acetylcholine and dilates bronchial smooth muscle. We use it on our bronchospasm patients with COPD as well as asthma if needed. What happens after you give it? Again, headache, dizziness, and nervousness. How do you give it? It's inhaled. Onset's about 1 to 3 minutes. Duration is 4 to 6 hours. Remember, if your patient is super sick and they have given themselves a few albuterol treatments and it failed, didn't work, make sure you go straight to this Duoneb and not repeat the albuterol. Dexamethasone. This is one of our steroids. It's a corticosteroid. It decreases inflammation by reversing swelling in the alveolar sacs. It's 25 times more potent than short-acting corticosteroids and 6 times more potent than prednisone. Onset is pretty rapid, and it lasts about 72 hours. This works really well with our anaphylaxis patients, asthma patients, and COPD. We can give it PO, IV, IM, or IO. Ideally, if they're not too short of breath, you want to give it to them PO, the 16 milligrams. If not, you can go ahead and give it IV, but it's only a singular dose of 16 milligrams. Pediatrics is 0.6 milligrams a kilogram up to that 16 milligrams. When it comes to packaging, please make sure you read the label because sometimes the concentrations are different with the manufacturers that give us our medications. So you can't always default to think, well, the dose is this is always 1.6 mLs because remember the concentration might be different. So please read the labels. And it lasts about 72 hours. Mag sulfate. Mag is one of those medications used for a variety of different things, and it works really well with our severe respiratory distress patients. Why? Because it's a vasodilator. It works really well with our status asthmaticus patients. We should never give it to a patient in a third-degree heart block. When you give this, you need to be careful of respiratory depression or hypotension. You can give it IV or IO. This needs to go on a medication pump. It needs to be given over 15 minutes. So for an adult, it's 2 grams. IV over 15 minutes. And a pediatric dose is 50 milligrams per kilogram to a max of the 2 grams over 15 minutes. How's it packaged? 1 gram and 2 ml. So if you need to mix this into a bag, typically the bag is going to be a 50 to 100 ml saline or D5W bag. You need 2 different vials of this, so that way there you can have 2 grams in your 4 mLs to which you infuse into the bag. The onset's pretty quick, and it lasts about 30 minutes. So that sums up our respiratory medications. Let's move into cardiac. Low-dose aspirin. So a lot of times our patients will take aspirin before we get there. Usually the singular dose of 324 milligrams is enteric-coated, meaning it's slippery and it's plastic. It's designed to be an extended release, not the non-enteric-coated, which we administer, that is chalky. So it comes in 81 milligram tablets. Our goal is to give 3 or 4 of these tablets to the patient to equal 324 milligrams. So even if the patient has taken aspirin prior to our arrival, it's okay if you turn around and piggyback it yourself with 4 81 milligram tablets, because who knows when the patient's aspirin actually expired. What does it do? It prevents platelets from clumping together. So it does not prevent clots. But what it does do, if there's a clot in place, typically if they're having a cardiac event, that your platelets become like slip and slide. So they bounce off each other. They won't stick to the clot. They'll go around the clot. We need to make sure not to give it to anybody who has active bleeding, hemophilia. Not recommended for pregnancy patients, and watch out for pediatrics with Reye syndrome. After you give it, there's always a risk of prolonged bleeding. It goes PO, again, it's 4 tablets, 81 milligrams, equal 324. The onset's 5 to 10 minutes, and it lasts 3 to 6 hours. Nitroglycerin, there's 2 different forms. We'll start with the tablets first. Also called Nitrostat. The onset's pretty quick, 1 to 3 minutes, and it lasts about 30 to 60 minutes. The big thing with nitro is it does lower your pressure, but it's short-acting vasodilator. So you want to make sure you always have a good blood pressure and make sure they're not hypotensive. Also, it's important to make sure that we obtain a 12 lead before giving nitro to make sure they're not having an inferior wall MI or a posterior or right-sided MI, because those are preload issues, meaning there's not enough fluid in the tank. So these folks need to get IV fluids in conjunction with their nitrate. So we give it when we think there's chest pain in nature that's not getting any better. We should not give it to patients that are hypovolemic, they're hypotensive, they have intracranial bleeding or a head injury. After you give it to them, you might have short-term hypotension. That's okay. It rebounds pretty quickly. But headache and dizziness is also very common. So sublingual, it goes underneath the tongue or in the cheek. You can either do it with a tab or a spray. It's packaged either 1 bottle of 25 tablets, or you can have a spray bottle with 60 metered sprays. There's a significant price difference between the two. And again, very quick onset, and it lasts a relatively short period of time. Second type of nitro that we deal with is nitro paste. So this is an advanced level medication as well as paramedic. So it's a smooth muscle relaxant that reduces cardiac preload by increasing coronary blood flow. Use it for our CHF patients. You need to be very careful if their blood pressure is not adequate or if they're hypotensive or hypovolemic, because remember, using this on CHF patients to which are probably getting a CPAP device, you have to worry about the increase in intrathoracic pressure from the CPAP device itself and lowering the blood pressure. That coupled with nitro paste could be lethal, so be careful with that. It's a transdermal, so it goes on a patch. So it's a 1 inch of the 2% paste applied to the anterior chest wall. So go ahead and put it right over the heart or where it's not hairy. That works as well. Onset's pretty quick. It's about 20 minutes. It lasts 8 to 24 hours. Sometimes patients in the hospital will have this patch on every single day, and the nurses will swap it out. But in the pre-hospital setting, we just apply it. For our CHF patients, if you start to see the blood pressure decrease and their mental status starts to change, this is also a great medication because you can take it off just as quickly as you put it on. So just remove the paste itself, wipe it down with a towel, and you're good to go and the paste is no longer there. Atropine. So on the cardiac route, if our patient's heart rate is slow, so bradycardic, and they are hemodynamically stable, we can go ahead and increase the heart rate by giving atropine. All that atropine does is it increases the chronotrophy in bradycardia, so it does rate only. It does not do anything with the squeeze of the heart or the electrical activity. It's exclusively tailored to rate. We should not give it if the patient's tachycardic or if they're having an MI or hypoxia, because it can make those two matters worse. After you give it, you can expect a tachycardia to ensue. Sometimes patients complain of chest palpitation. You can give it IV and IO. You can also give it IM. IM is typically used for organophosphate poisoning. Bradycardia in an adult. So again, heart rate less than 50, that they are hemodynamically stable but not maintaining very well. You give 1 milligram to a max of 3. Pediatrics weight-based. And then if you need to give it IM due to organophosphate poisoning, those are the dosages there. How is it packaged? 1 milligram and 10 mLs. Onset's pretty immediate, and it lasts 4 to 6 hours. Adenosine. So this is the opposite of atropine. So this is when we have our patients to which they have a rapid heart rate. We need to slow it down. Typically they're an SVT or monomorphic or regular VTAC. So all it does is slow down the conduction through the AV node. We should not give it on any second or third degree blocks if they're an AFib, aflutter, or irregular VTAC with a pulse. What happens after we get adenosine? So remember, adenosine is a rapidly acting medication with a really short half-life, meaning about 6 seconds before the half-life kicks in. So this needs to be a rapid IV push. So large bore IV and the AC is ideal, large bore being either an 18 or 20 gauge IV needle. After we have a bag of fluid going to them, you can use a 3-way stopcock if you're comfortable with that. If not, you can just have it hooked to a bag with some flushes ready to go. So you give the first dose, 6 milligrams rapid IV push, and it's immediately followed up by a fluid bolus. If it is effective and works, you might see something called an asystolic pause or a long sinus pause that could last up to 10 seconds. A lot of times patients will complain of dizziness, tunneled vision, sweating, or palpitations while this is going on. We can give up to 3 doses, 6, 12, and 12. If this doesn't work and they become unstable, then we need to go ahead and synchronize cardiovert. It's packaged in 5 vials, and each of them have 6 milligrams and 2 mLs. The onset, again, is immediate, about 6 to 10 seconds of a half-life, and the duration is relatively quick, 1 to 2 minutes. Metoprolol. So this is a medication that we use to lower a heart rate in rapid AFib or atrial flutter. So the goal is to decrease the heart rate, and it lowers the blood pressure as a side effect. We don't give it to people in heart failure, second or third degree blocks, or if they're hypotensive. After we give it, they might become dizzy, they might become hypotensive, and we need to watch out for a spontaneous bronchospasm. This is one of the medications that you give slowly. So the cardinal rule of thumb is 5 milligrams and 5 mLs over 5 minutes. So 5 over 5 over 5. And once you get conversion of the rate that you're looking for, so if they're in rapid AFib and you have given 3 milligrams or 3 mLs over 3 minutes, and you notice that they're in a sinus rhythm, you can go ahead and stop. You don't have to deliver all 5 milligrams. It's a beta blocker that works directly on the beta-1 adrenergic receptors, and it directly affects, again, the heart rate and the contractility of this. Onset is super quick, usually 30 to 45 seconds. If it starts to work, you'll see a change, and the duration is 4 to 8 hours. Amiodarone, one of our antiarrhythmics. So what it does is it prolongs duration of the action of potential in the refractory period in arrest. It means it gives us a chance to get them back. When would we give it? So we're talking about VFib, pulseless VTAC, or VTAC with a pulse. We should never give it to somebody in a second and third degree heart blocks or someone in cardiogenic shock. After you give it, they could start to throw different type of arrhythmias or go into a bradycardic rhythm. We give it IV or IO. So the 2 different doses we give it. So if they're pulseless, so during arrest, we do 300 milligrams the first time, then a round of epi, and then 150 milligrams IV, followed by a round of epi. If they have a pulse, we simply just give them 150 milligrams. It's packaged in 6 vials of 150 mLs. 6 vials of 150 milligrams and 3 mLs. The onset's about 2 hours, and the duration is unknown. Fun fact about amiodarone, it is a super foamy medication. So if you need to draw up 300 milligrams, and that, let's say, is 6 mLs of the medication, use a normal saline flush, get rid of 6 mLs of normal saline, go ahead and draw up the 6 mLs of amiodarone into that 10 cc syringe. It will make it less foamy. If you try to draw up amiodarone into a dry syringe, it's going to take a long time, and it'll be very hard to measure because of the amount of foam in your syringe. Epi 1 to 10,000 or 1 to 10. I like to teach, you're going to give epi 1 to 10,000 in a cardiac arrest because you have a 1 in 10,000 chance of getting the patient back. Remember, epi 1 to 1,000 is for anaphylaxis. So epi 1 to 10,000 is our first line cardiac arrest medication. It's one of those meds that it's very common that we run out of. We typically only have 5 to 7 dosages of pre-filled syringes. If for some reason we run out of this medication during cardiac arrest, remember we can always make our own. We make our own by taking a 10 cc syringe or a 10 cc flush, get rid of 1 ml, and then you draw up 1 ml or 1 milligram epi 1 to 1,000, so the anaphylaxis dose. So you draw up the epi 1 to 1,000 into your syringe of 9 mLs of saline. That gives you the same exact concentration as the epi 1 to 10,000. The onset's pretty rapid. The duration is 20 to 30 minutes. Give it IV and IO only. This medication should not go down the tube, nor should it be given IM. So let's go into diabetes. Our first line medication for someone who's hypoglycemic and able to swallow is oral glucose. Oral glucose is an EMT level medication. Our goal is to go less invasive before we go too invasive. So if they have a blood sugar that's 55 and they're able to swallow, you want to go ahead and give them the oral glucose. Just know the onset Takes a little bit of time. We're talking 10 minutes or so. And the duration is depending on each patient on whether or not it's going to be in there stored or used rapidly, whether they take insulin or not, and so forth. But just know we need to give it to conscious patients to which we suspect hypoglycemia. We figure that out by grabbing a blood sugar. We should not give it to our patients if they have a decreased level of consciousness, they're unable to swallow, or they're nauseous with vomiting. After you give it, depending on how they respond when they're hypoglycemic, as they start to come back to a normal blood sugar, they might become combative, so be careful of that. How much do you give? Just go ahead and give one tube. It's about 15 grams. Just know when it comes to packaging, people can buy tubes of glucose that are more than 15 grams. I think there's a 25 gram one out there or a 30 gram one. So make sure you have the right one you want to give. If for some reason, if your service does the 30 gram tubes, just give them half the tube. The onset again is about 10 minutes. You need to make sure they are well fed if they decide not to be transported to the hospital, because the glucose stores will be used up rather quickly for most of our patients. D10. D10 given at the advanced level in paramedic. What does it do? Like the oral glucose, it increases serum glucose levels, so this is like a liquid carb lunch. Give it for hypoglycemic patient as well as neonatal resuscitation. We don't want to give it to anybody who's hypovolemic. We want to make sure we get fluids on board. It's not a substitution for hypovolemia. We can give it IV or IO. Again, IO is last ditch effort. So it's packaged as 250 ml bag, which equals 25 grams. So we want to go ahead and start an IV, have some fluid go and introduce this D10, and then titrate to effect. Once we get them more alert and conscious and the blood sugar is greater than 60, 70, or 80, we can go ahead and stop, because the goal is us not to put them into a hyperglycemic state. The onset is 1 to 2 minutes, so it's slow and steady, and the duration again is patient dependent. So I like to throw this slide in with the D10. This is part of our protocol. If the blood glucose is less than 60, so that's our cutoff. The patient's conscious and able to swallow. Again, you want to give the oral glucose first. Otherwise, if they're 40 kilograms or more, you can administer dextrose 25 grams IV. So that would be the D50, which we're going to cover next, or the 250 ml of D10W solution, which I would advocate for, because remember, diabetes didn't happen overnight, so we shouldn't be treating it as quickly. So if we do a D10 infusion, it's easily regulated and we won't spike their blood sugars into hypoglycemia. If the patient weighs 40 kilograms or less when it comes to the D10, the protocol does a really good job of giving us a little table on the weight of kilogram and pounds, especially newborns, and then the volume to be infused. Meaning if you have a patient who weighs 20 kilograms or 44 pounds, you're going to start off by giving them 100 mLs of D10, recheck their blood sugar after 5 to 10 minutes, and then if you need to give more, go ahead and give more, but 100 mLs should work well on a patient who weighs 20 kilograms or 44 pounds. As I alluded to in the last slide, another opportunity we have to give glucose is D50. So this is a pre-filled syringe. This pre-filled syringe is designed to rapidly, and I can't say that enough, rapidly increase serum glucose levels. We give it with hypoglycemia with altered mental status, so I would ask you guys to reserve this medication. So if you have that patient who's super combative or someone who is unresponsive and seizing, this is where D50 is important to get on board quickly. And remember, you don't have to give the entire amp in order to get them out of their hypoglycemic state. Dextrose 50% is super necrosis and necrotic, so if you are pushing it through an IV line and it infiltrates and you don't catch it, it can be necrotic to the tissue. That's super bad. If you give them the whole amp of D50, they might go from a blood sugar of 42 to 442. So now you put them in a DKA state. That's not too great. And then again, if you wake them up too quickly, they might become really combative, and oh boy, that's not fun either. So D10 is definitely a better alternative to this. If you're going to give this D50, again, it's a slow IV push. I would always suggest giving half the amp first, recheck a blood sugar, and then give the other half if you need to. The onset is quite immediate, and the duration, again, is patient dependent depending on comorbidities or how much insulin they take on a regular basis and how much insulin they took prior to your arrival if they're on it. Glucagon. Glucagon can be given at the advanced level as well as a paramedic. So this is your Hail Mary treatment for hypoglycemia. This is a hormone secreted in the pancreas. The patient needs to have stored supplies of glycogen or it will not work. We can also give it for beta blocker or calcium channel blocker overdoses. We should not give it to these patients if they are hyperglycemic. Again, glucagon is to dump the stores of glycogen that they have in their system. So if they're already hyperglycemic, you don't want to release more. After you give it and they come around, they might become combative. This medication, regardless if it's for hypoglycemia or for the beta blocker, calcium channel blocker overdose, you go ahead and give it IM. The way it's packaged usually comes in a small plastic kit. You have 1 milligram of the glucagon medication as well as 1 ml syringe of sterile water. You take this syringe, put it into the 1 milligram of the glucagon in the vial. It's a powder. You then roll it gently between your fingers. Don't shake it. And then you give it to them IM. Onset's up to 5 minutes. Up to 5 to 10 minutes is very slow, and the duration is 15 to 20 minutes. Our next category of medications I termed as lifesavers, and you'll see why. Ondansetron. Here's your Zofran. Given at the advanced level, what it does is it blocks the action of serotonin, and serotonin is what initiates vomiting. When do we give it? We want to prevent and control nausea and vomiting in our patients. This is acceptable to give to OB patients as well. When not to give it, when they have a history of prolonged QT syndrome. If you ask a patient before you give the Zofran, if they have a history of prolonged QT syndrome, one of two things are going to happen. The first one, they're going to look at you like you had 3 heads. I would take that as a no. They do not have prolonged QT syndrome. The second response is they go, absolutely, my doctor said I had something to do with my heart if I took Zofran. That's called prolonged QT syndrome. What prolonged QT syndrome is exactly what it says. It's the QT part of the EKG rhythm that becomes wide, and it puts your patient into VTAC. What may happen after you give it? Most patients complain of a foul taste in their mouth. You can give it IV or PO. You have 4 milligram tabs, or you have 4 milligrams via IV. The onset's pretty rapid. Duration is 2 to 4 hours. In my personal experience, most patients do the best after they get their second dose to equal 8 milligrams total. Naloxone. This can be given at all levels, also known as Narcan. Just know this is also what the public carry. They carry the 4 milligram intranasal sprays. Typically the public as well as PD carry that. So if someone said I gave Narcan in the field, meaning non-EMS, it's most likely 4 milligrams. What does it do? It reverses respiratory depression secondary to opiate only by binding to opiate receptors. We give it if they have respiratory depression or respiratory arrest with a pulse due to opiates. When not to give it, when they're in cardiac arrest, Narcan does not work if you don't have a pulse. Even though we do perform high-performance CPR, it's still not adequate enough for Narcan to circulate through the system. So only give Narcan once you get ROSC if you think it was secondary to opiates to help with the respiratory effort. After you give Narcan, depending on the amount and how they respond, because everybody's different, they can become combative. They can start to have seizures, especially if you put them in withdrawals, or become short of breath. How much do you give for an adult? You have 0.1 milligrams to 2. For PDs under 25 kilograms, you're talking 0.1 milligram a kilogram. Over 25 kilograms, that puts you in the 55 pounds plus. You're talking 0.1 to 2 milligrams, just like an adult. Never, ever, ever give it to neonates. How is it packaged? It's a preloaded syringe, 2 milligrams and 2 ml. So for most adults, you're going to give either 1 milligram or 2 typically. The onset, so if you give it IV, it's 1 to 2 minutes. If you give it IM, it's 2 to 5 minutes. And if you give it intranasally, it usually takes a little bit longer, upwards of 10. And the duration, it lasts about 30 to 45 minutes. Examples of opiates to which this works on: morphine, heroin, methadone, fentanyl, codeine, Demerol dilaudid. Midazolam. This is the benzo. It's also known as Versed. It helps us with our seizing and or combative patients. So we use it on seizures, anxiety when we do CPAP, or post-intubation when we get ROS so they don't buck the tube, in combative patients. We should not give it to patients that are in shock, are currently in a coma, or they're heavily intoxicated by alcohol. Alcohol slows everything down. It's a downer. So it slows your heart rate, makes you more calm, and it can alter you and make you sleepy. Benzos do the same thing, and Versed is a benzo. What may happen after you give it? You got to watch out for CNS and respiratory depression. How can we give it? IM, IV, IO. So it's typically given in 3 different ways or reasons. One is seizures. If you have a seizing patient and you show up on scene, don't waste time and get an IV, IO. Go ahead and give them the 10 milligrams IM if they're an adult. You can repeat one time up to a max of 20. If they're combative, again, go with the IM route, 4 to 10 milligrams. If they have anxiety when you go to put a CPAP on, again, you can do an IM dose. So again, Versed, think IM first before you do IV, because you waste valuable time trying to get an IV. How is it packaged? 5 milligrams per 1 ml. Onset IM is 2 minutes versus IV, which is a minute. So there's not a huge difference in the absorption rate of this medication, and it can last upwards of 2 hours. One thing about Versed being a benzo is we do not have a pre-hospital reversal. The reversal agent for this is Ramazicon. So if you happen to give Versed and they become super altered or they become respiratory depressed, you can go ahead and just ventilate them, maintain their airway, keep their end-tidals with the normal ranges and the sats up, and then it will wear off eventually. It'll be perfectly fine. Mag sulfate, again, the medication that can be used for a variety of different things in our protocol. Magnesium sulfate can be used as an anticonvulsant or anti-seizure medication for a patient who is pregnant. Usually use it when they're eclamptic. Don't give it in 3rd-degree heart block. After you give it, watch out for CNS depression, respiratory depression, or hypertension. We give it IM. How much do we give? We usually give 8 grams in 4 mLs in each buttock, or 4 grams IVIO over 10 minutes. How is it packaged? You have 9 different vials of this, 1 gram and 2 mLs. Remember, if you're going to give IM injections, you don't want to do any more than 2 to 4 mLs per injection so you don't overwhelm the site. The onset's immediate. It lasts about 30 minutes. Eclampsia is defined as a life-threatening emergency due to seizures in pregnant or postpartum women. Typically occurs in the 3rd trimester or up to 6 weeks postpartum. It presents with extremity swelling, high blood pressure, abdominal pain, and severe headaches. If your patient presents with any one of these, and either they're pregnant in the 3rd trimester or they're up to 6 weeks postpartum, in the back of my mind, I'll be thinking I might need MAG for this one. Ketamine. Paramedic only medication. We can use it for a couple different reasons. The one we're going to kind of highlight today is your combative patient. So what does it do? As a dissociative effect, it's an analgesic and a sedative. We use it on our combative patients, patients that have anxiety while using CPAP, and we also use it for pain relief. We should not use it if there's increased ICP, severe hypotension, or acute heart failure or MI. What happens after you give it, depending on the dose, they might start to hallucinate. They start to hallucinate. You gave them the wrong dose. They didn't give them enough. Then excellent state of calmness. That's when you know you had the right dose for this patient. How do you give it? IV, IM, intranasal. So we cover 3 different reasons for this to give it. So ketamine first, you can use it in pain. So you're talking abdominal pain, fractures, burns. Combative patient. So on the dosing with this, it's 4 milligrams per kilogram to max of 500 milligrams. It's packaged as 1 vial of 500 milligrams and 5 mLs. So the goal for giving this medication during a combative scenario is you want the dissociative effect. What that is you want to be able to give them enough medication to which it makes their body really calm and they pretty much disassociate from their body and they don't realize what's going on. Their vital signs won't change. They'll be in more or less a deep sleep, but they're not going to be stuck in the mixture of both of them where they might be combative or hallucinating. Again, if they are hallucinating, you didn't give enough of the medication. So basically, if you have a patient weighs 200 pounds, they're going to get at least 400 milligrams. If you have a patient that's 250 to 300 pounds, you're going to go ahead and give them the full dose of 500 milligrams. We can also use it for post-intubation so they don't try to pull the ET tube out or if they're super anxious with CPAP. Duration, so IV, it's immediate, but for most of these patients, at least in the combative patient, you're not going to wait and try to get an IV. You're just going to give an intramuscular, and that is in a 3-minute onset, and duration is 15 to 25 minutes. All you need to do to be able to give this when it comes to our protocol is to make sure that they're a +4 on the Alta Mental Status Scale. Please take a moment, look up that protocol. It's not hard to get our combative patients to fall into that category. So let's go into pain management. Again, ketamine you can use for pain management as well if you choose. First one's acetaminophen, so this is your Tylenol. It can be given at the EMT and advanced level with a little bit of uniqueness depending on application. So EMTs can give this medication PO only. Advanced EMTs and paramedics can give it IV. So we can use it as an analgesic, so it's pain relief, or we can use it to reduce fevers. We should not give if patient has alcohol abuse, because again, can be toxic to the liver. After you give it, they might have abdominal pain, and again in high levels on toxicity of the liver. How do we give it? PO ideally, or you can give it IV. How much do you want to give? 10 milligrams per kilogram. You're out to the nearest 80 milligrams, the max of 1,000 milligrams total. They're typically packaged in 160 milligram chewable tablets. The onset, if they choose to have this medication or you administer it, it's about 30 minutes, and then duration is 4 to 6 hours. It is absorbed rapidly and completely from the GI tract. It does not affect inflammation or platelet formation. It is believed to work on the CNS by allowing smooth muscle contraction, therefore assisting in the healing process. Again, EMTs can do PO. Advanced EMTs can do PO or IV. If it's an adult IV, they want us to put it on a pump because you're going over 1,000 milligrams. It's a pediatric IV. Of course, you always put it on a pump. Nitrous oxide. Wonderful medication. A lot of services don't have it, but there are some that do. So all it is a 50-50 mix of oxygen and nitrous oxide. It's a CNS depressant with analgesic properties. We can give this for moderate to severe pain. It works really well on pediatrics. It works really well on frail, skinny, elderly folks. We need to make sure that we give it to them. They don't have an impaired level of consciousness. They don't have a head injury, and they don't have a pneumo. What may happen after you give it or while you're giving it, they might become lightheaded or drowsy. How do you give it? It's just an inhaled gas. So it's self-administered, and you titrate to effect. So you need to take your nitrous mixer as well as your nitrous tank. Your nitrous tank ties into your nitrous mixer. That nitrous mixer you then tie into a portable oxygen tank through the high pressure hose, so the one that you screw on, not the one that you plug in a BVM or nasal cannula to. Turn the oxygen on, and then it's self-administered. So they can hold a mask to their face. They can use the mouthpiece of a duoneb treatment canister, put it in their mouth, and they just kind of breathe. The faster they breathe, the more medication they have. The slower they breathe, the less medication they have. If and when they have had enough, they can just stop breathing in the nitrous. It wears off in about a minute or so. If they feel the pain coming back on again, they can start breathing this medication back in again. Perfectly safe. It's good to use for select types of patients, but just know if you go down the route of giving nitrous, a lot of physicians typically won't go down the IV opioid route with us in the field. So if you call on the medical control, say, hey, I started this patient on nitrous, I want to go ahead and give him some fentanyl as well. They may not give you that order, or they might say, only if you stop the nitrous, give it a period of time, and then go ahead and give the fentanyl. Fentanyl. Wonderful opiate. It is 50 to 100 times more potent than morphine. It does not bottom out the blood pressure like morphine does, so you shouldn't see a whole lot of subtle vital changes, except maybe the respiratory rate. In order to be able to monitor real-time respiratory effort, don't forget about the use of end-tidal CO2. So it's a CNS depressant. It's a potent analgesic. We use it for pain management. We should not give it to breastfeeding mothers because it will cross the barrier from the milk into the patient. And then any patients that are on multiple opiates, if we gave them some fentanyl on top of the opiates that they're already taking, it may put them into a respiratory depression or a CNS depression state. If so, because it's an opiate, we have the reversal. It's Narcan, so always have that ready to go. Give this medication IV, intranasally, or IM. The initial dose should not go over 100 mics, and then it's not to exceed 5 mics per kilogram. How is it packaged? We have 100 mics in 2 mLs, so if you want to give only 50 mLs, it'd be 1 ml. Excuse me, if you only give 50 mics, it'll only be 1 ml. The onset IV is 1 to 2 minutes. Intramuscular is 1 to 3 minutes. Intranasal is 5 minutes, and duration is 1 to 2 hours. So let's talk about some of our utility meds. So they have good usages, but they're used only in particular scenarios and not very multifaceted. First is lidocaine. So this is a paramedic level medication. It's a topical anesthetic. We should use this if we're going to put an IO in a patient who is alert. It helps offset the pressure when we start to infuse medications to a pressure bag through that IO. If you give it, just know they might have anxiety or become drowsy. It's an IO medication. You're not going to give this through IV. In an adult, it's a 4 milligram slow IV push followed by a saline flush. And then if you need more, you call medical control. How is it packaged? 100 milligrams and 5 mLs. The onset is pretty immediate and it lasts about 10 to 20 minutes. Tetracaine. Paramedic level medication. It's an anesthetic for the eye, and it's most effective after you rinse the eyes of any debris. If there's any penetrating trauma, you would never put this in. But what it does is it just numbs the eye. It's just an eyedropper. You would directly over the affected eye. You drop 2 drops every 5 minutes to the affected eye after 3 dosages. If you need more than that, call medical control. It's in a very small bottle. Onset's about 30 seconds. Duration is 15 minutes. Sodium bicarb. It's a medical level medication. It buffers metabolic acidosis and lactic acid buildup. We can use it with crush injuries to observe hyperkalemia, so PT waves during entrapment, tricyclic antidepressant overdoses, aspirin overdoses, and known metabolic acidosis during cardiac arrest. Meaning this is not a medication that we give on every patient in cardiac arrest. What is a known metabolic acidosis? This includes known DKA patients or known patients that have potassium imbalances. Usually it's secondary to dialysis. So if they're on dialysis, this would be a great medication to give during cardiac arrest. Please know that there are no studies out there that provide improvement in patient outcomes when this is routinely used during cardiac arrest. After you give it, they go from acidotic to alkalosis. This is kind of the D50 in the lactic acid world. How do you give it? IV-IO, depending on the issue, is how much you're going to give. Look at your protocols. You have a couple of boxes of pre-filled syringes of 50 milliequivalents and 50 mLs, very similar to that of D50. It's a big syringe. Onset's immediate and duration is unknown, but it directly affects the pH. Calcium gluconate, another paramedic level medication, is used to stabilize the cardiac membrane by increasing the threshold potential during hyperkalemia. So we see it again with our crush injuries, usually post-entrapment, or if they have known potassium issues. When not to give it, we should never give it in the same line as sodium bicarb because it will crystallize. So if you need to give sodium bicarb and calcium gluconate, it needs to be on 2 different IV drip sets. It cannot be on this going to the same site. It will crystallize where they meet. We give it IV-IO. This is never IM. It needs to be on a pump, 1 gram IV over 5 minutes. Pediatrics, 20 milligrams a kilogram. IV over 5 minutes to a max dose of 1 gram. It's packaged as a 10 milligram per ml in vials. Onset's immediate and duration is 30 to 60 minutes. Because you're dealing with the cardiac membrane in hyperkalemia, this should be a patient who you're cardiac monitoring regularly as well as doing 12 leads. Pitocin, paramedic level medication, also known as PIT. So it stimulates uterine smooth muscle, producing contractions similar to those in spontaneous labor and has a vasopressor effect. In the pre-hospital setting, is not designed to induce labor. More, it's designed to vasoconstrict from a hemorrhage after birth is done. So we need to make sure we use it after the delivery of the fetus and the placenta. We need to make sure you have the child and the placenta that come out and not one and not the other. We should not give it if there's known multiple fetuses. If you have twins or triplets, just know it's a very chaotic birth typically, and we're not going to worry about throwing PIT into this process. We're just going to deliver all these babies and placentas first. It's an IM injection, 10 units per ml. So you give 1 dose of IM PIT. Onset's 3 to 5 minutes and duration is 30 to 60 minutes. IV therapy. This is our infusions. Normal saline, advanced level. So we use it to replace volume in the vascular systems for rehydration purposes. So we should use it for hypovolemia, shock, and hyperglycemic patients. We should not give it with patients with congestive heart failure or renal failure dialysis. The only caveat to that is if they are septic, you can go ahead and give it to both of those patients. Remember, anytime you are giving IV fluids, you want to make sure lung sounds and blood pressure are closely monitored. Very rare side effects from this. You're going to give it IVIO. In our hypovolemic shock, we want to make sure our goal is to maintain a blood pressure of 90 systolic. In pediatrics, 20 mLs per kilogram to maintain a good normal blood pressure for them. It can be packaged in 250 ml bags, 500 ml bags, and 1,000 ml bags. Anytime you're infusing a medication like saline, remember our goal is blood pressure. So what's the MAP? Remember what MAP is? It's mean arterial pressure. So it's the average arterial pressure throughout one cardiac cycle that includes systole and diastole. The normal MAP is 60 to 80, with 70 being the target range. So take your blood pressure. It's that little number that's automatically calculated for you. It's measuring the systolic and diastolic pressures. Lactated ringers. Another advanced EMT and paramedic medication. Replaces volume and electrolytes in the vascular system. We should use this on our patients that are heat stroke, heat exhaustion, burns, and sepsis. When should we not give it? Again, be very careful of the CHF patients or the ones that are on renal failure with dialysis. Also, we should never run lactated ringers and blood through the same line. They're not compatible. So if you think blood is coming in the future, either run saline or a secondary line just for the blood while you run the LR. We give it IVIO. For heat emergency, our goal again is to keep the blood pressure around 90 systolic. With burns, that's the Parkland burn formula. So we give a lot of fluid up front and then we taper it as the time goes on. I really wanted to hone in on sepsis. So if we have a patient who we suspect has sepsis, their goal is fluid resuscitation in the field. Sepsis kills more people every year than heart attacks and strokes combined, and we miss it all the time, especially in our elderly patients who are altered with fevers. They need to get 30 mLs a kilogram of LR. So what does that mean? If you have a patient who's 100 kilograms, that's 3,000 mL, so that's 3 liters of fluid. It's a lot. How is it packaged? 250 ml bags, 500 ml bags, or 1,000 ml bags? Again, like with the saline, check out the maps. Make sure it's between 60 and 80 with 70 as the goal. And LR should never be used in substitute of whole blood or packed red blood cells. Infusion mixing bags. In our kits, we have 100 ml saline bags, 250 ml saline bags, and 100 ml D5Ws. Depending on the medication, it specifies in the protocol what we need to mix our medications with. So just be aware of that, but know that there are typically 3 different opportunities for us to mix our medications. TXA, medical level medication. A lot of trauma docs love to see TXA on any trauma that requires critical care, but we don't use it on people post-birth. We're going to use PIT for that, okay? So what does it do? It binds to plasminogen, which prevents clot breakdown. We use it if a patient's hemorrhaging out. We don't want to give it to head injury patients, pregnant patients over 24 weeks, under 16 years of age, any trauma injury over 180 minutes old, or anybody with known hypercoagulated state, so they have blood disorders. What happens after you give it? If you do it rapidly or too fast, you can cause hypotension. So this really needs to be on a medication pump infused over 10 minutes. What is it? It's 1 gram and 250 mLs over 10 minutes. The onset's about 5 minutes and duration is 3 hours. Please know the 1 gram that we're allowed to give in the field in the ambulance is only half of the dose that's required. So if you give TXA in the field, make sure you let the trauma doctor know that you only gave 1 gram and they will complete the 2nd gram. The only agency in Maine in the pre-hospital setting that can give the full 2 grams is Lifeline of Maine. Ceftriaxone. So what does it do? It binds to the bacteria cell wall membrane, causing cell death, so it's an anti-infective. We use this on any patient who has an open fracture. When not to give it, if a patient has known allergic reactions or anaphylaxis to penicillins or cephalosporins, that also is up to debate depending on the facility you go to. What happens if you give it? They may have allergic reaction to it. Remember, if you're ever giving any sort of medication that a patient starts having an allergic reaction to, the first thing you do is stop the medication and then treat the anaphylaxis. It needs to be given on an IV infusion on a medication pump. How much do we give? We give 2 grams of IV medication and 50 mLs of saline or D5W over at least 10 minutes. Again, it's not to be gravity fed fast into your patient because you have to look for the allergic reaction piece. How does it come? Usually it's 2 1-gram bottles of powder and then the bag of mixing fluids. You have to use a syringe, a 10 cc syringe, mix it in the bottles of powder, roll the medication around inside the bottle, and then you draw it back up again and mix it into your bag of fluid. Onset's immediate and duration is 12 hours. Mag sulfate. There it is again. Who knew we could give it for so many different things? Mag sulfate. We also saw this underneath the severe respiratory distress or status asthmaticus. We can also use mag sulfate for antiarrhythmics. So if you have a patient who's in torsades de pointes, we need to give it. It's a very rare condition that usually is very quick. So it's very hard to capture this, but if you happen to capture it and you have an IV established and the med all drawn, go ahead and give it. Don't give it in a 3rd-degree heart block. Watch out for CNS depression, respiratory depression, and hypotension. You're going to give it IV and IO through a pump. 1 to 2 grams IV over 5 minutes. The onset's pretty quick and the duration is only 30 minutes. Epi 1 to 1,000. 1 to 1. So we can do an epi infusion if they have a severe allergic reaction that the IM epi and Benadryl is not working. So we can put them on a continuous infusion. We do have to call online medical control for this, but it blocks histamine receptors. It increases heart rate, contractility, electroactivity, and blood pressure. So watch, you'll see a change in heart rate and blood pressure as well with this. Use it for severe anaphylaxis or severe reactive airway disease. No, do not give it if they are hypertensive because you're going to jack the blood pressure up indirectly by giving them medication. After you give it, they may become restless and have headaches and or tremors. IV infusion, there's the doses that you need. Feel free to pause the screen and read it. The onset's immediate and it lasts about 20 to 30 minutes. Amiodarone, another paramedic medication. It's our first line antiarrhythmic for refractory VFib, pulseless VTach, and Y complex unstable tachycardia when cardioversion is unsuccessful. Remember, amiodarone is super foamy when you draw it up, so draw it up into a syringe of 10 cc syringe and do it nice and slow. What it's designed to do is increase coronary artery blood flow in VTach. This is if they have a pulse. We're going to infuse it. We're not going to push it. Don't give it in 2nd and 3rd-degree blocks or cardiogenic shock. What happens after you give this medication? It's an antiarrhythmic, so you could have an arrhythmia occur and or bradycardia. IVIO, an infusion pump when a pulse is present. You're going to give 150 milligrams mixed with D5W over 10 minutes. The onset's up to about 2 hours, so it's not rapid acting, but it does start relatively immediate. But just know the full therapeutic effect could last up to 2 hours, and the duration is unknown. Norepi, or Levophed. Paramedic level medication, typically used in our post-ROSC patients. So it's a potent alpha antagonist resulting in peripheral vasoconstriction. So basically shunts all the blood from the extremities to the heart. We should use it on cardiogenic shock secondary to unsuccessful fluid resuscitation. We need to get at least 1 liter of fluid into our folks, if not 2, before we consider Norepi, because it's not to be given for someone who is hypovolemic or doesn't have enough fluid in the tank. We need to be careful of reflex bradycardia in response or arrhythmias. We give it on an IV pump. So we start off by mixing 8 milligrams and 250 mLs of saline, a starting dose of 0.03 mics per kilogram per minute, and we titrate to maintain a blood pressure around 90 systolic, so we can change the drip rate every 3 to 5 minutes. The max dose is 0.6 mics a kilogram a minute. The PD is the same exact dosing. Onset's immediate, duration is 1 to 2 minutes. So this is one of those medications to which every time you alter the dose up or down, you really need to monitor the blood pressure. So this is one where you would take a blood pressure even more frequently, typically than 3 minutes. So if you had to take a blood pressure every minute or at least every 3, 5 is pushing it because a lot of changes can happen in 5 minutes. So very closely monitor the blood pressure. When you get a blood pressure that you like, you keep it. Just know if you increase it rapidly or too fast and don't wait every 3 to 5 minutes, you can put them into lethal arrhythmias like VTAC. So in summary, know your medications, know why you're giving them, know the routes to give them, know what to do if there's an undesired effect, have a backup plan if your initial treatment doesn't work, and remember patients, as long as they have all their faculties, have the right to refuse medications. Med Math 101. Let's apply some of this knowledge to some real life scenarios. First and foremost, true or false? All medications expire at the end of the month unless otherwise specified on the original medication. True. So again, if the medication just says it expires in September of 28, it's September 31st, 2028, not September 1st. On the flip side, if you have a medication that clearly says it expires on February 9th, 2028, it expires on February 9th, 2028. All right, so let's talk about acetaminophen. You have a 190-pound male with 6 out of 10 traumatic shoulder pain who refuses narcotics due to the fear of becoming dependent on them. How much acetaminophen are you going to give? So the first thing you need to do is convert 190 pounds to kilograms. So 190 divided by 2 minus 10% puts you at 85.5 kilograms. So 85.5 kilograms times 10 puts you at 855 milligrams. 5 tablets are 800 milligrams. 5.5 tablets is 880 milligrams. Fentanyl. You have a 76-year-old male weighing approximately 75 pounds who fell down the stairs and broke his leg and is complaining 9 out of 10 pain. You cleared his C-spine already, but how much fentanyl did you want to give him before you move him and how? So the dose of fentanyl is 0.5 to 1 mics per kilogram with a max of 100 on your first initial dose. You can give it Q5 minutes to a max dose of 5 mics per kilogram. So first, let's change the 75 pounds to kilograms. So 75 divided by 2 minus 10% puts you at 34 kilograms. So if you want to start off at 0.5 milligrams per kilogram, you're talking 17 mics. Kind of hard to measure, but you could do it. Or if you want to do the full dose of 1 mic per kilogram, that would be 34 mics a kilogram. So realistically speaking, it'd probably be easier just to start with 40 mics a kilogram because again, your weight's approximate. So you give the 40 mics up to a max of 5 mics per kilogram. TXA. You respond to a 40-year-old victim who was stabbed in the stomach and upper leg. After successfully applying a tourniquet to the leg, you established an IV and started some normal saline. Now you want to give TXA. How much are you going to give? So with TXA, remember, the dose is 1 gram and 250 mLs over 10 minutes via IV infusion pump. So you're going to give the full gram over 10 minutes on that pump. Narcan. You're dispatched to a 14-year-old female weighing approximately 110 pounds who overdosed on heroin and is breathing 3 times a minute. How much Narcan do you need to give her and how? So while you're figuring out the medication, apply end-tidal and start to ventilate them with a BVM. While that's going on, remember the dose of Narcan is 0.1 to 2 milligrams IV, IO, or intramuscularly. So for a female patient like this, you could go ahead and give a single milligram if you wanted. Remember, if the public or law enforcement gives intranasal, that's 4 milligrams all at once. So take that into consideration. Aspirin. You respond to an 80-year-old male with 9 out of 10 substernal chest pain with radiation down his right arm. You confirm he's having a STEMI with a 12 lead and activate the cath lab in the field. How much aspirin you want to give him and how many tablets is that? Remember the aspirin that we give, 81 milligram tablets. The dose is 324 milligrams. You want to go ahead and give 4 baby aspirin or 4 81 milligrams. Remember, our aspirin is non-enteric-coated. The ones that people typically take in their home is a singular enteric-coated, so it's slippery and plastic in nature. It's extended release of 324 milligrams. If they took this prior to your arrival, it is still okay to go ahead and re-administer pre-hospital aspirin because we can't guarantee the medication that they took is in date. Midazolam or Versed. You dispatch to a 44-year-old female weighing approximately 155 pounds who is having a seizure. Upon arrival at the grocery store, you notice that she is having a seizure in one of the aisles. How much Versed do you want to give her and what route? So remember, the protocol allows us just to go ahead and give it intramuscular. An adult, 5 to 10 milligrams. I would go ahead and just give 10 as an adult female. So walk up, give her 10 milligrams IM immediately. Don't waste any time getting an IV. Get the medication on board. Then you can safely package her after dealing with the airway, apply the oxygen, ventilate, whatever you need to do, and then get her in the back of the truck and work on the IV later. But again, person actually having a seizure, when we show up, grab the narcotics, give them the IV correction, the intramuscular injection of 10 milligrams until you can get the IV in the back of the truck on the way to the hospital. D50, you respond to a known diabetic's house for a 51-year-old male having a low blood glucose episode. Upon arrival, he's confused, not combative, but unable to follow basic commands or swallow oral glucose. Did you want to treat him with D50 or D10 and why? How much did you want to give of either? So remember what I kind of educated you on, diabetes wasn't formed overnight, so we shouldn't be fixing these diabetic emergencies immediately, too quick, because if we give them a lot of sugar at the beginning to go from a hypoglycemic state to a normal, a lot of times we overshoot it with D50 and put them right into DKA or HHNK, so which the blood sugar could be anywhere between 300 and 700 after we give the D50. So I would go ahead and advocate, because this patient is not combative, to go ahead and start him with the D10 and infuse, half the bag, a quarter of the bag, or the full bag, and then check the sugar after that. If they became super combative or they started seizing, I would change it to D50 instead and give the AMPA D50. But remember, there's a lot of things that occur with D50. We can blow the line and then cause necrosis and put a ball of sugar in their bicep or wherever we started the IV. And if we bring them from a hypoglycemic state to a DKA state, they can become very, very combative. Epi, you respond to a 5-year-old weighing approximately 50 pounds, having an allergic reaction to peanuts. What's the concentration of Epi and what do you want to give? How much and what route? So you need to break it down into kilograms. So 50 divided by 2 minus 10%. Put you at 22.5 kilograms. So the dose in the protocol book is less than 25 kilograms, 0.5 milligrams of Epi IM. Because that patient's in that 50 to 60 pound range, again, it's all approximate with the weights that we guess. It's okay if you give her 0.3 milligrams, the adult dose, because they're right on that weight cusp. Worst case scenario, if you go with the 0.15 milligrams of Epi, 1 to 1,000 IM, you may have to redose them. Sodium bicarb, dispatched to a 32-year-old male weighing approximately 265 pounds, big fella, who crushed both of his legs in an industrial accident. After starting IV and hook him up to the 12 lead, intending a 12 lead, it's peak T waves. You and your partner decide to give sodium bicarb. How much and how do you want to administer it? So 265 divided by 2 minus 10% gives you about 120 kilograms. The dose is 1 milliequivalent per kilogram IV over 5 minutes to a max dose of 50. So again, this patient typically outweighs the dose that you have on hand, so that you're only going to be able to give the 50 milliequivalents. So the max dose that we have on hand, you can put it on a pump. Calcium gluconate. So after giving that same patient the sodium bicarb, you decide to go ahead and give the calcium gluconate as well to help with the peak T waves. So how much you want to give them, how much you want to administer it. This is 1 gram IV over 5 minutes, set dose. Put it on an infusion pump, so that way there you can control it. Ketamine, you dispatched to help the police with an out-of-control 27-year-old male weighing about 240 pounds, and you've determined that he's a +4 on the AMSS scale, so which gives you the green light to give ketamine. How much ketamine and what route do you want to give? So 240 divided by 2 minus 10% puts him around that 108 kilogram or 110 kilogram for easier math. Your dose on hand is 500 milligrams and 5 mLs. The protocol says 4 milligrams per kilogram, so 4 times 110, so 4 milligrams times 110 kilograms, the patient's weight. Makes you want to give 4.4 mLs out of the 5 mLs you have available to you. So you're going to give 440 milligrams of ketamine. Again, we carry 500 on the truck. Mag sulfate, 67-year-old male weighing approximately 150 pounds with severe shortness of breath, who is also tested positive for COVID. You've already utilized his MDI. You've given him IM-EPI, 2 duo-nebs, and an IV of dexamethasone, and decided that you still want to administer a bag of mag sulfate to assist with his difficulty breathing. How much and what route do you want to treat this patient with mag? So the protocol for mag for the respiratory status asthmaticus, our difficulty breathing, is 2 grams IVIO over 10 minutes. And the dose on hand is 1 gram and 2 mLs. So you're going to take 2 different vials. That way there you can have 2 grams and 4 mLs. You're going to then inject that into a bag of 50 to 100 mLs of saline or D5W, and then infuse it over 10 minutes on an IV pump. Norepi, also known as Levophed. You have successfully resuscitated a 62-year-old male weighing approximately 190 pounds in the field to achieve ROSC. After almost 2 liters of saline during the resuscitation effort, you decide you want to administer Norepi. How much and how did you want to do this? So the first thing you need to do is change your approximate weight in pounds to kilograms. So 190 pounds divided by 2 minus 10% puts you at 85.5 kilograms, or about 85 kilograms for this patient. Again, everything's approximate. Your protocol states to start off, you do 0.03 mics per kilogram per minute. So 85 times 0.03 puts you at 2.55 mics a minute. Then you then have to mix up your bag. So you're going to do 8 milligrams of Norepi and mix it in your 250 ml bags of saline. And then you go ahead and start them on the medication pump. Just know it's about 1.195 drops a minute. Oxygen. You respond for a 91-year-old female weighing approximately 80 kilograms, complaining of shortness of breath. Her aroma O2 sat is 91%. How are you going to treat her with oxygen, and how? So, current rule of thumb is you want to make sure the oxygen saturation for most of our patients is between 94 and 99%. Remember, a 91% oxygen saturation on a COPD patient actually is very good, or probably normal for them. So start off with your nasal cannula, ideally with end-tidal CO2. You can increase the nasal cannula up to 6 liters as needed and make sure they're breathing through their nose. If for some reason the nasal cannula doesn't work, I would go ahead and step it up to a non-rebreather. And the non-rebreather doesn't work, depending on the condition, probably a CPAP. If the CPAP doesn't work, you'd then go to a BVM. Remember, the goal is to keep SAPs between 94 and 99% and the end-tidal CO2 between 35 and 45. Thank you, everyone, for attending my presentation. I hope you took something away from it. Again, I know it's a lot of information. Please feel free to watch this wherever you need to and as many times as you want. Again, use your protocol book is a good thing to refer to when it comes to medication dosages and when to use them. Any questions at all, please email me below with my first and last name at yahoo.com.